a couple of cases regarding advanced HCC and living donor liver transplant, as that is something that we do quite a bit of at the Starzl Institute. So I will, oops, sorry, that is not what I wanted to do. So what is the rationale for liver transplantation? So before I start, I wanted to thank everyone and all the presenters for all their extensive information and knowledge that we've had all day today on HCC. And one of the things that we discussed is that liver transplantation is an option for hepatocellular carcinoma, and it potentially for some could be curative and also prolong life expectancy. So like I said, the treating the lesion, it allows, especially if HCC is multifocal, or it can provide oncologically superior margins. And it also treats the underlying disease, which is the cirrhosis, the portal pressure, and the hepatic function by giving a liver transplant. So there is a rationale for pursuing liver transplantation. Now, the purpose that I'm discussing living donor liver transplant is that it gives us a different way to address transplantation as opposed to not just deceased donor transplants, because as we discussed, there is a overall organ shortage, and to be able to provide organs to everybody that may need it. So living donor gives us a chance to maybe transplant people that fall outside of a category of being able to be transplanted, or gives us also a chance to plan and schedule at an optimum time for the patient, so that we're able to help more people. And as you can see, this graph is more of the representation of how UPMC has evolved in its living donor numbers. And as 2020, our projected was, we'd done about 100 living donor transplants. So that was, there is a growth in that. And also the fact that we've had good results. This is our SRTR data from 2021 of this year, with the observed and patient survival and graft survival being quite high. It does allow us to take higher risk cases, especially cases that may fall outside of Milan criteria when it comes to HCC. The next few slides are going to be about presentations. I will preface that with Dr. Christopher Hughes, who's our liver director. The next drawings that you will see are all him. He's an excellent surgeon as well as an artist, so the credit for the next few slides will be all him. So this is a patient. She's a 31-year-old female from Virginia. She developed abdominal pain back in August of 2014. It was biopsy confirmed hepatocellular carcinoma. She presented to us in November of 2014. At the time of her diagnosis, she'd lost about 20 pounds and also had undergone 2 TACE in October of 2014. So she presented to us and we worked her up because she had an extensive disease. As you can see, her entire liver was just fibrolamellar. HCC, this is clearly outside of any criteria for her to be able to be listed on a deceased donor transplant list, and also not really resectable at this point. So we had evaluated her for a living donor transplant to give her an option for being able to restore her liver function, also maybe give her disease-free survival. Our normal pre-op bone scan and chest CT didn't show any extra hepatic disease, and then so because of that, we were able to proceed. And she also had low fractional leaflet loss, so that also helped us say that we could maybe proceed with a living donor transplant from her molecular testing. So for her, she got a left graft or left lobe graft from her brother. So it was a living related, and this is pretty much what a left lobe graft will look like. So this is the blue on top are the hepatic veins. The red in the hilum down here are the artery. The other blue is the portal vein, and the 2 greens are the 2 bile ducts from this donor graft. So we attached the hepatic veins to the middle and left hepatic veins. They went to the left hepatic vein. Then we attached the artery. Let me see if I can get to the next picture. Okay. So the left hepatic artery was attached to the right hepatic artery from the recipient. The portal vein was attached to the main portal vein. And the 2 ducts were sewn as a single duct in a Roux Y to reconstruct the biliary enteric anastomosis. So this was her surgery that was performed. Her total operative time was about 12 hours. Her graft weighed 492 grams. She had good flows through her graft. The portal flow was about a liter a minute. And then, so it was about 203 mLs per 100 grams of tissue, which is appropriate flow. She had good hepatic artery flow, and it was actually a low transfusion for a liver transplant. She only received 2 units PRBCs throughout the entire case for over 12 hours. This was her pathology, again, showing extensive tumor burden. Subsequently, she did well initially postoperatively, but in about a year post-op, she did develop pulmonary nodules. She was started on sorafenib and later added FOLFOX to her treatment. She also developed metastases to her cervical vertebrae, as well as L5, T7, and T8. She did die on January 21st, 2019, but her survival after transplant was 3 years, 11 months, and 2 days. So there was an extension to, being able to give her some more time with her extensive disease burden. So that's our first case. And I'm just going to quickly give another similar scenario. However, this one is a 47-year-old. She was diagnosed with fibrolamellar HCC back in California in 2001. The reason I listed this her entire course is that you can see that she was basically had several resections. She had initially even been accepted at UCLA for transplant because at that time she fit the criteria, but then she had lung mets and had to be removed from the transplant list. Subsequent to that, from 2010 to 2017, she had liver resections, lung ablations, had multiple rounds of chemotherapy, was even on phase 1 trials at UCLA, and subsequently had to be DC'd from elevated LFTs. So she presented to us early in 2018 with, again, with fibrolamellar HCC, and at this point also a increased ascites and a decreased functioning liver. She did not have any evidence of tumor anywhere outside the liver, and so we decided to accept her for a living donor liver transplant. With all of our cancer patients, we do begin all of our surgeries with a exploration, and she had a negative exploration. We did not appreciate anything extrahepatic on our initial exploratory laparotomy that would preclude us from proceeding with the living donor transplant. So on April 5th, 2018, she also got a left lobe in similar pictures as before. Here she had 2 arteries, and they were sewn to the right hepatic artery and the GDA. And then she had 2 ducts. Again, a Roux-en-Y was performed. For her operative time was 15 hours. Cold ischemia was 164 minutes. Warm ischemia was 27 minutes. And she did receive about 6 units of PRBC and 1 FFP. Her pathology to reflect. Her postoperative course, she did have refractory ascites. There was concern that there was steel from the splenic artery, so she did go to IR post-op day 5 for a splenic artery embolization. And then currently for case, she has no evidence of intra-abdominal metastases, but she did develop pulmonary metastases on day 292 after her living donor transplant. But again, she does not have anything in her abdomen yet. She has had multiple ablations, and she's had removal of lung nodules. She also had a VATS for her lung lesions from 2018 to 2020. But she is currently still alive. She's 3 years, 6 months post living donor liver transplant. And currently, because of her lung metastases, she's on limantinib. So I think she's still has gotten a chance progress for almost 4 years now, despite having a pretty aggressive cancer for 17 years.